Welcome all. This is the second part of the NICE guideline, fertility problems, assessment and treatment. And it also covers unexplained infertility and ART. So in the first part, what we have seen is the male factor investigations, female factor investigations, and the basic treatment for ovulation induction and for the male factor. Here, we are going to discuss about the unexplained infertility and the ART, and you will get at least one or two EMQs from this particular next 15-16 slides. Okay, so at least two SBAs and two EMQs on this particular topic there will be in the examination. Okay. So unexplained infertility. So we will not offer oral ovulation stimulation agents such as clomiphene citrate, anastrozole, or letrozole in cases of unexplained infertility. Clomiphene citrate alone is ineffective, does not increase the pregnancy or live birth rate. Expectant management is the first management in cases of unexplained infertility. So advise regular unprotected intercourse for a total duration of 2 years. This period may include up to 1 year before fertility investigations. Okay, so if you have given a long scenario in which you look for the male factors, you look for the female factors, what evaluation have been done, and what is the duration of the infertility. Suppose through in the scenario you come to know it is a unexplained infertility where male factors are normal, female factors are normal, and if they have given it is just 1.5 years of infertility, you will choose the option that try for 6 months with regular intercourse every 2 to 3 days. Okay, so because 2 years are not over. Okay, if the 2 years are over, then choice will be the in vitro fertilization. Okay, so IVF will be an indication. Offer IVF if pregnancy has not occurred after 2 years of regular unprotected intercourse. Okay, so read the scenario carefully, then choose the option. So key take home message is unexplained infertility, no oral ovulation induction, 2 years try naturally, and then you go for IVF. This is what is the option which you need to select. Now, regarding the intrauterine insemination, when to consider unstimulated intrauterine insemination as an alternative to vaginal sexual intercourse, there are very specific indications for IUI. So, when you are selecting this option of IUI, please see to it that you are aware of this specific indication. That is, people who are unable or find it difficult to have vaginal intercourse due to physical disability or psychosexual problems, such as using partner or donor's sperm, people requiring special conception methods like post sperm washing in HIV positive male and same sex couples. So these are the only three categories. That is, either there is a physical disability where the sexual intercourse, vaginal intercourse is not possible, or psychosexual problems are there, or it is a same sex couple, or there is a disorder like HIV positive male. These are the only three categories in which you will select the IUI as an option. Okay. So what should be the duration before IVF in eligible couple? If there is no conception after 6 cycles of donor or partner insemination. Okay. So if with 6 cycles of donor or partner insemination, there is a normal ovulation, then tubal patency is also normal seminolysis, then you will give another 6 cycles of unstimulated IUI. Okay, unstimulated IUI for 6 cycles, and then you will consider IVF after 12 cycles. Okay, so if the couple is on IUI protocol, in that particular case, first 6 cycles, then another 6 cycles, and then after 12 cycles you will give option for IVF. Okay, now IUI in common infertility patients, unexplained infertility, there is no role. There is a mild endometriosis, again no role of IUI. Mild male infertility factor, again there is no role of IUI. So when you are dealing with this, please do not select an IUI as an option. Okay, there is another talk on unexplained infertility. That talk does mention a role of IUI. Okay, and it is mentioned clearly in the talk. The NICE guideline does not recommend the IUI for unexplained infertility, but practically it is used at certain centers. Okay, that also has been mentioned. Okay, but unexplained infertility, mild endometriosis, and mild factor infertility, do not select IUI as an option. Only three indications which we have already discussed. Okay. Now, exception is that if there are strong social, cultural, or religious objection to IVF. Okay. In that particular case, you may select IUI as an option. Then advise regular unprotected intercourse for total 2 years before IVF. Okay. And it may include up to 1 year before the investigation also. Now, what are the factors which will predict the IVF success? Okay, so one is a female age. Live birth rate decline as the age increases. Okay, then previous failed cycles. Success reduces with increasing number of unsuccessful IVF cycles. Previous pregnancy and live birth. IVF is more effective if woman has conceived before. Okay, if she has conceived either naturally or with IVF, there is a more success rate. Then BMI, ideally it should be 19 to 30, and outside the range there is a reduced success. Okay. Then lifestyle factor affecting IVF. Alcohol more than 1 unit per day will reduce the IVF success. Maternal smoking, paternal smoking will also adversely affect the success, and maternal caffeine intake reduces the success rate of IVF. So take home message is that IUI is unstimulated and used only in specific situations. There is no routine IUI for unexplained infertility, mild endometriosis, or mild male factor infertility. 2 years, try naturally, and then we will give the option for IVF. IVF success rate decreases with age, high or low BMI, smoking, alcohol, and caffeine. Okay, these are the factors which are associated with low success rate. Previous pregnancy has got a better IVF outcome. Okay. Now coming to the access criteria for IVF. Again, here EMQ is asked. So please listen this slide carefully. Okay. Discuss risk and benefit of IVF in line with the HFEA code of practice, that is Human Fertilization and Embryology Authority, HFEA. Okay. So we have to discuss the risk and benefits of IVF. Explain that one full IVF cycle with or without ICSI, what it includes. One is episode of ovarian stimulation and transfer of all resulting fresh and frozen embryos. So that includes one full IVF cycle. Okay, that means you have given the stimulation appropriately, and you have got say 5 or 6 or maybe more number of eggs. Then how many embryos will be formed? All those embryos you will be transferring in various cycles. Okay, so that includes one full cycle. Okay, now how many cycles we need to offer? Okay, so this is the EMQ. Eligibility by the female age and the IVF entitlement by the age group. Now if the woman's age is less than 40, then you will give 3 full cycles of IVF with or without ICSI. Now one full cycle means one ovarian stimulation and transfer of eggs resulting from, or the embryos which are resulting from that particular ovarian stimulation. Okay, now this is performed after 2 years of regular unprotected intercourse or 12 cycles of artificial insemination. And if her age is more than 40, then you will offer 3 full cycles of IVF with or without ICSI. If she turns 40 during the treatment, you will complete that particular cycle only. There will be no further cycles which you are going to offer. If her age is between 40 and 42, you will offer her only one full cycle of IVF with or without ICSI, but she must meet all 3 criteria. These criteria are: there should not be any previous IVF treatment, no evidence of low ovarian reserve, and informed discussion about the risk of IVF and the pregnancy at this, because her age is increasing. So it is going to be a very high risk pregnancy that has to be discussed. Okay. So these are the things which you should. So sometimes they can give you this age of the patient will ask the how many cycles are required. So depending upon age, but if you are selecting between 40 and 42, in that particular case, please ensure that these criteria are met. Okay. Now, cancelled IVF cycle. When we say that the cycle is cancelled, if the egg collection is not undertaken, then we say that the cycle is cancelled. Okay. Cancelled cycle due to ovarian reserve should be considered when we are deciding the suitability for further IVF. Okay. If the number of cycles are getting cancelled and then due to, especially with the low ovarian, whether to give this IVF as an option, that we need to relook into it. So the key take home message here is, what is full IVF cycle? It is a fresh plus frozen embryo transfer resulting from one stimulation. Okay, and less than 40 years we will offer 3 cycles. Between 40 and 42 we will offer 1 cycle. That is the strict criteria. All previous cycles will get counted. NHS are self-funded. Cancelled cycles still matter, especially if it is due to low reserve, and direct IVF referral if no chance with the expectant management. Okay, if there is no chance with the expectant, then only direct IVF referral. Okay, otherwise 2 years of infertility, 2 years of regular sexual intercourse, and then only you offer the treatment. Okay, now what are the procedures used during the IVF treatment? Okay, generally pre-treatment in IVF is required, which may be in form of OCP or progesterone, but does not have any effect on the live birth rate. It may be used to schedule the IVF cycles, or in women not undergoing long down. It may be used in women not undergoing long down regulation protocols. Okay, so it does not have any relation with the live birth rate, but it will help to schedule the IVF cycle. Okay, then prevention of premature LH surge. Okay, for this, use regimens to prevent the premature LH surge in gonadotropin stimulated IVF. Use either GnRH agonist down regulation or GnRH antagonist. Okay, so for premature surge prevention, GnRH agonist down regulation protocol or GnRH antagonist are to be used. Okay, so GnRH agonist specific guidance, what it says, who should receive? Those patients who are low risk of OHSS only should receive this GnRH, and protocol should be long down regulation protocol. Okay, so it is a long down regulation protocol and GnRH agonist only if the patient is low risk for OHSS. And we have already seen in the previous session which are the patients who are high responders for gonadotropin. Okay, then third is a controlled ovarian stimulation. Okay, general principle is that ovarian stimulation is mandatory in IVF. Then use either urinary gonadotropins or recombinant gonadotropins. Okay, the FSH starting dose should be individualized, which is based on the age of the patient, BMI of the patient, presence of polycystic ovaries, and the ovarian reserve. Maximum dose per day is around 450 international units. Monitoring during ovarian stimulation should be by the TVS, plus minus you do the estradiol levels, and the purpose of monitoring is assess the efficacy and ensure safety. Okay, now natural versus stimulated IVF. Okay, clomiphene or gonadotropin stimulated IVF has got higher pregnancy rate, while natural IVF cycles are not recommended. Okay, it is always stimulated cycle, either clomiphene or gonadotropin stimulated IVF, that has got a high pregnancy rates. Then coming to the trigger during the IVF. Okay, offer human chorionic gonadotropin, that is SCG, either urinary or recombinant. Ultrasound monitoring is an integral part of the cycle. IVF units must have clear protocols for prevention, diagnosis, and management of OHSS. Then next step is a oocyte and sperm retrieval. Okay, for oocyte retrieval, the transvaginal route. So it is ultrasound guided transvaginal oocyte retrieval. Offer conscious sedation. Then follicular flushing is not recommended if more than 3 follicles are present. Does not improve oocyte yield or pregnancy rate, and increases the pain or the procedure time. So oocyte follicle flushing is not indicated. For sperm retrieval, surgical sperm retrieval before ICSI. Technique will depend on the pathology and the patient preference. Cryopreservation facilities must be available. Okay, so that is one of the important thing, that you need to have a cryopreservation facilities. So the key take home message here is, pre-treatment cycle. Pre-treatment is important from the cycle scheduling point of view only. Then GnRH agonist or antagonist will prevent LH surge. Okay, important is to prevent the LH surge. The maximum FSH dose is 450 international units per day. There is no role of natural cycle IVF, no growth hormone, DHEA, or assisted hatching. Conscious sedation for oocyte retrieval, and OHS protocols are mandatory. Okay, so these are the things which you should remember. Now coming to the embryo transfer strategies in IVF. Again here there will be EMQ. Okay, please concentrate on this particular slide. technique and endometrial factors. So ultrasound guided embryo transfer should be used. Improves pregnancy rates. Embryo transfer is not recommended if the endometrial thickness is less than 5 millimeter. Post embryo transfer, only around 20 minutes of bed rest is indicated. More than 20 minutes does not improve IVF outcomes. Then embryo quality assessment, evaluate embryo quality at cleavage stage and blastocyst stage. Use AC and UK NEQAS embryo and blastocyst grading system. Will not go into that, but we need to evaluate the embryo quality at cleavage stage and the blastocyst stage. The number of embryos to transfer. It is an age-based strategy, whether it is a fresh or the frozen embryo transfer. This is the thing which can be asked in the examination. Okay. So if the female's age is less than 37 years, then how many embryos you will transfer? In the first cycle, it is always a single embryo transfer. In the second cycle, if top more than one or more top quality embryos are available, then you will go for single embryo transfer. If not, then you will go for double embryo transfer. And third cycle, always double embryo transfer. Okay. So look at the age of the patient and then select how many embryos you are going to transfer. So what you have to see, whether the top quality embryos are available or not, and whether what is the age of the patient. If the woman's age is less than 37 years and top quality embryos are available, in that particular case, single first cycle, single embryo transfer. Second cycle, top quality embryos available, single embryo transfer. Double embryo only if top qualities are under, and third is always double embryo transfer below 37 years of age. While 37 to 39 years of age, they will give you exact borderline. Okay, it is less than 37. If they give you 37, then in that case, this particular will be. So first and second cycle, if top quality embryos are available, you will go for single embryo transfer. Okay, if it is not available, then you will go for double embryo transfer. In the third cycle, always double embryo. Okay. And if her age is between 40 and 42 years, again, they may give, here they have very clearly said 30 and 39. Here it is 40 to 42. Any cycle, always double embryo transfer. Okay. So 40 and onwards, it is double embryo transfer. Below 37, first cycle, single embryo transfer. Second cycle, single embryo if the top quality is available. Otherwise, double embryo. Third cycle, always double embryo. Okay. So please remember how many embryos, because this is specifically asked in the EMQ. Okay. Now, special precautions when the donor IVF is considered. Embryo transfer strategy should be based on the donor's age. Okay. And the top quality blastocyst available in that case, use single embryo transfer only. Then safety limits and counseling, maximum embryo per cycle, not more than 2. Okay. Now, when double embryo transfer is considered, counsel regarding multiple pregnancy risk. Then coming to the cryopreservation. Offer cryopreservation for remaining good quality embryos after the transfer. Frozen thawed embryo transfer. In women with a regular ovulatory cycle, live birth rates are similar with whether it is a natural cycle or hormone supplemented cycle. Okay. So embryo success rate is similar. Then luteal phase support is always with progesterone. SCG not used routinely, it increases the OHSS rate, and continuous support beyond 8 weeks, there is no evidence that it is beneficial. Do not select gift and zift. These options are not to be selected. Okay. So here the key take home message is ultrasound guided transfer mandatory. Endometrium less than 5 millimeter, avoid transfer. Single embryo transfer is always preferred, especially with top quality blastocyst. Never more than 2 embryos. Always counsel about multiple pregnancy and free surplus good quality embryos. Okay. So please read all the options very, very carefully and select the options properly. Okay. Now coming to the ICSI. There are very specific indications, and again this is asked in the EMQs. Okay. What are the specific indications for ICSI? If there are severe semen abnormality, obstructive azoospermia, non-obstructive azoospermia, and failed or poor fertilization in previous IVF. Okay, so OA and OA, that is obstructive oospermia, non-obstructive oospermia, failed IVF, and severe semen abnormality. These are the four indications for ICSI. Okay, ICSI, the fertilization rate is better, uh, but not the pregnancy rate. Okay, ICSI will improve the fertilization rate, but the pregnancy rate will be same. Genetic counseling, when genetic counseling or testing is required, so what are the situation? Suppose there is a known or suspected genetic defect causing male infertility, offer genetic counseling and testing. Okay, if there is any known or suspected genetic defect which causes male infertility, we will offer genetic counseling and testing. There is a severe semen deficit or non-obstructive oospermia, always establish male karyotype. Again, this is a EMQ question. They will give severe semen abnormalities and will ask you the next investigation. So before IVF, though the ICSI is a treatment, before that you have to establish the male karyotype. So if you have an option, select the karyotype as an investigation and then the ICSI. Okay. Then male undergoing karyotype testing, we will always offer genetic counseling. Okay. Y chromosome microdeletion, not routinely recommended as a test before ICSI. Couple should be informed that a significant proportion of male infertility is related to Y chromosomal gene abnormalities affecting the spermatogenesis. Okay. Then ICSI versus conventional IVF. Okay. Couple should be informed that ICSI improves fertilization rates compared with the IVF alone. Once fertilization occurs, outcomes such as embryo development, pregnancy rate, live birth, they are all similar to the conventional IVF. So ICSI and IVF, only fertilization rate is improved. So the key take-home message here is ICSI is mainly for male factor infertility. Always consider genetics before ICSI. Karyotype is required in severe semen deficit and non-obstructive oospermia. Why microdeletion testing is not advised routinely, and ICSI improves fertilization, not post-fertilization outcomes. Okay, so I hope this is very, very clear, okay, to all of you. Then coming to the donor insemination. So which cases require donor insemination? If there is obstructive or non-obstructive oospermia, severe semen abnormality, okay, then high genetic or infectious transmission risk, severe RH isoimmunization. Okay, so in this particular case, you may go ahead with a donor insemination. That is OA or NOA, obstructive or non-obstructive oospermia. Then severe semen abnormality, high genetic or infectious risk, then severe RH isoimmunization. Key principle: IUI is preferred over intracervical. This also we have seen. Regular ovulation, 6 unstimulated cycles minimum. Okay, if she is regularly ovulating, offer her 6 donor cycles. Okay, then tubal assessment, routinely not done. If it is a low risk case where we are not suspecting any PID or endometriosis, we will straight away offer 3 cycles. If the 3 cycles are failed, then you will go for assessment, tubal assessment. If she is high risk for any other factor, then you will go for, before you start the IUI treatment, you will do the tubal assessment. Okay, so which are the patients which are high risk for tubal factors? If there is a previous PID or history of ectopic or previous pelvic or tubal surgery or known case of endometriosis, you will first do the tubal patency and then you will give her IUI treatment. But if these factors are absent, then you will give 3 cycles of IUI, and if they are failed, then you will go for tubal assessment. Okay. Then oocyte donation indications are premature ovarian failure, Turner syndrome, bilateral oophorectomy, post chemotherapy, radiotherapy, recurrent IVF failure, and high genetic risk transmissions. Okay, and there is always a mandatory counseling for donor as well as recipient. Okay. Now, people with cancer who wish to preserve the fertility. Okay, sometimes the question can be asked on this also. So, general principle is that we will follow the guidance, the effects of cancer treatment on reproductive functions. So, these are the there is a guidance which is published in 2007. When offering cryopreservation before chemotherapy or radiotherapy, likely to impair the fertility. Okay, at diagnosis, we will discuss the impact of the cancer, impact of plant treatment, and future fertility options. They need to be discussed at the diagnosis itself. Okay, factors to consider before offering fertility preservation. Always consider the cancer diagnosis, planned treatment, prognosis, expected outcome of future fertility treatment, and viability of stored and post-op material. Okay. Now, what are the eligibility rules? Do not apply conventional infertility eligibility criteria for cancer-related fertility preservation. Okay. So, routine conventional infertility guidelines or eligibility criteria are not applicable. No lower age limit for cryopreservation in people with cancer. Inform patients that eligibility criteria do not apply at storage stage. They do apply later when you using stored material for NHS funded assisted conception. The methods of fertility preservation. So permitted options for sperm, oocytes, and embryo. Men and adolescent boys offer sperm cryopreservation before gonadotoxic cancer treatment. Preferred technique is a freezing in liquid nitrogen vapor. Okay. For women and adolescent girls, offer oocyte or embryo cryopreservation if medically fit for ovarian stimulation and egg collection. Procedure will not worsen their condition and sufficient time exists before the cancer treatment. So look how much time you have. Then you offer this either oocyte or embryo cryopreservation. And cryopreservation technique will be vertification will be preferred if equipment and expertise is available. Now storage duration. For all cryopreserved material, initially it is a 10 years storage. Then sperm for ongoing infertility extend storage beyond 10 years. Okay. Long-term safety of ovulation induction and ovarian stimulation. Provide up-to-date information on long-term outcomes. Inform women that no direct link with the invasive cancer, no short-term or medium-term adverse outcomes in the children, and long-term data is still unavailable. Okay, lowest effective dose and shortest effective duration is to be used. For women, absolute risk is low. Small increase in the borderline ovarian tumors cannot be excluded. That we need to mention. And for children, absolute long-term risk is very low. Okay, this we have discussed. Then limit IVF drugs to lowest effective dose and shortest durations. The key take-home message for cancer fertility preservation is separate from the routine infertility rules. There is no age cutoff for cryopreservation. Men go for sperm cryopreservation. For women, you can go for oocyte and embryo cryopreservation if the time and fitness allow. Vitrification is preferred for oocytes and embryo. ART drugs give minimum effective dose and long-term risk low, but we need to counsel them appropriately. For women, absolute risk is low, but there is a small increase in the borderline ovarian tumors that cannot be excluded. Okay, so that finishes the topic of the NICE guideline on the fertility. Okay, thank you.